Hi, my name is Lonnie Zelli, and I decided to do my presentation on pressure ulcer prevention. On an individual wound basis, according to Medicare, pressure ulcers are the second leading cost of all wounds. And wounds on average have an annual cost of $28 million. Acute wounds with substandard treatment can turn into chronic wounds very easily. When wounds become chronic wounds, it can lead to a loss of work, decrease in ability to perform ADLs, and depression. Pressure ulcers can affect anyone, but mostly affects the elderly and spinal cord injury patients. The patients that spend the most time in their bed or the chair, and any type of patient that has any type of limited mobility. Common sites of pressure ulcers injuries are heels, ankles, hips, and tailbones. Pressure ulcers are developed in the hospital and are largely preventable and very costly. Stage 3 and Stage 4 pressure ulcers are not reimbursed. Pressure ulcer injuries can develop in as little as 2 hours. As pressure ulcers contribute to significant patient burden and increased healthcare costs, their prevention is a clinical priority. Pressure ulcers affect around 10 to 30% of hospitalized patients worldwide and contribute to significant patient burden and healthcare costs. The purpose of this project is to see if using a preventative treatment on a bony prominence in the hospital can prevent skin breakdown. Some of the things that need to change. Nurses and staff need to be educated on prevention. Nutrition, including what kinds of foods and drinks that the patient at risk should be eating and drinking, such as high-protein foods, unless contraindicated. Education on importance of prompt incontinence changes with using a barrier cream afterwards. Education and follow-through on the education that they were originally taught. Some of the data. As mobility is a natural defense to alleviate prolonged pressure on the skin, extensive exposure to pressure from lying or sitting on a specific part of the body renders the patient at a greater risk for skin breakdown. The annual costs are approximately $10.7 billion. According to the American Association of Wound Care, the average cost per year to heal one pressure ulcer is $3,400, which is just the supplies and the doctor costs. It does not include any surgical intervention costs if they are needed. When a patient develops a pressure ulcer in the hospital, reimbursement is provided until the patient develops a Stage 3 or Stage 4. Then the hospital gets nothing back financially. And that's only if the ulcer is developed while the patient is in the hospital. According to the Agency for Healthcare Research and Quality, prevention is difficult because of 5 reasons. It is multidisciplinary. Nurses, physicians, therapists, nutritionists, families all need to be invested for this plan to work. It is multidimensional. Many discrete areas need to be mastered. It's customized. Each patient is unique and should be treated that way. It is routinized. The care needs to be performed as ordered, which may include several times daily. It cannot be missed. It's not considered glamorous. People look at wound care as to be not as important as other aspects of nursing, but it is a necessity. When it's not taken care of or addressed, it could potentially kill the patient. Some of the preventions that are used in the hospitals in our area, Kaleida Health, Catholic Health, and Roswell Park, are a risk assessment is completed upon admission. If at risk, an Aleve foam is placed on a bony prominence and changed every 3 to 5 days. Skin assessments are completed by the nurse with their daily assignments. Nutrition consult to make sure their nutrition is where it needs to be, and a therapist consult for pressure relief such as wedges, heel booties, hill run beds. All three of the major local hospitals use the same assessment for assessing patients at risk for pressure ulcers. A multidisciplinary approach is used, and everyone needs to be involved. All three use a dressing on the bony prominence and hope that the skin stays intact. Because of the prevention strategies at the hospitals is how I came up with the research question of, among bed chair-bound patients, how does using a preventative dressing on a bony prominence compared to no dressing impact pressure ulcer rates over a 90-day period? The first article I used was an article regarding studying the nurses' perceptions of the usefulness and impact of a pressure ulcer prevention care bundle intervention on clinical practice. The nurses that were interviewed found the care bundle easy and acceptable. They identified a number of benefits from the bundle, including improved communication, awareness, and participation in pressure ulcer prevention amongst the patients and the staffs. And they also came to the conclusion that it was not appropriate or effective for everybody. The relevance is protecting the patient from getting a pressure ulcer helps to prevent pain, discomfort, save money and time that could be used doing something else for the patient. Making sure that the nurses are on board with prevention is the key. Without the nurses' help, prevention wouldn't work. The method studied was a qualitative descriptive study. It involved a semi-structured interview. 4 to 5 nurses at each site were questioned about the care bundle. The bundle of interest consisted of 3 things that the nurse and the patient had to follow. Keep moving, look after your skin, and eat a nutritious meal. The nurses had positive views and found that the pressure ulcer prevention care bundle was feasible and acceptable. They found the bundle easy to understand, use, and implement. However, did acknowledge some barriers in engaging some patients in the pressure ulcer prevention care. The second article talked about pressure ulcer prevention in ICU in critically ill patients. Pressure ulcer cumulative incidence was significantly lower in the intervention group compared to control group. The intervention group had a significantly less stage 1 and stage 2 pressure ulcer development. The relevance, patients that are in the ICU or critically ill are more at risk for pressure ulcers, so coming up with ways to prevent them is of utmost importance. Utilizing a bundle approach in a standardized nursing language through skin assessment and translation of knowledge to practice has the potential to impact positively on the quality of care and patient outcome. A 2-arm cluster randomized experimental control trial, which means that some patients were in the control group and some were independent. Significant improvements were observed in the pressure ulcer related outcomes with the implementation of the pressure ulcer prevention bundle in the ICU. The incidence, severity, and total number of pressure ulcers per patient were reduced. The third article was to evaluate the processes of implementation of the care bundle and patient and staff perceptions of the bundle in order to give a deeper understanding of the effects of the intervention. It was found that a 42% reduction in the risk of pressure ulcer with this intervention. The study explored processes related to the implementation of the care bundle intervention, encouraging active patient participation in the pressure ulcer prevention care and promoting a nurse-patient partnership. The nurse and the patient have to be equal participants for the prevention. Neither one can do it alone. A mixed method process evaluation was used Quantitative and qualitative data were collected across evaluation domains: recruitment, reach, intervention, delivery, and response to intervention, at both cluster and individual patient level. Quantitative data was analyzed using descriptive and inferential statistics, and qualitative data was analyzed using thematic analysis. This process evaluation found no major failures related to implementation of the intervention. The care bundle was found to be easy to understand and to deliver. My design. My plan of change, maybe not necessarily to change, but to add on. Do not just go by the Braden scale. Not everyone at risk shows up on the Braden scale. It's better to over-identify the patients than to under-identify them. Education should be for all staff and not just nursing. Patient and family education for when they go home. The independent variable, the preventative dressing. To implement change, I would do a comparative design which would work best for this question. I would compare the results with using a treatment versus not using a treatment. Using patients that have a history of pressure ulcers or at a risk for pressure ulcers should be utilized for this change. Placing a preventative treatment on the bony prominence should be done upon admission to the hospital and not hours after the paperwork is completed. My modifier would be education. Education is needed to get best results. Without education for everyone involved in the case, no change can happen. You start from the bottom and educate everyone on up regarding prevention, nutrition, therapy, and pressure relieving devices. Implement and evaluate. Stakeholders are the patients. They are the ones who suffer if they develop a pressure ulcer. The team members, nursing, aides, therapy, dietary, environmental services, everyone and anyone that has a part in the care needs to be involved in that patient's case. The benefits, patients will have no skin breakdown while in the hospital. The risk, maybe they might have an allergic reaction to the preventative treatment and make the patient worse than they originally were. Training. Staff needs to be trained regarding turning and positioning every 2 hours, keeping wrinkles out of sheets, offloading pressure points, nutrition to evaluate and make sure that the diet is adequate. And that should be initial eval upon admission. Therapy to do in-services for nursing staff to teach about pressure relieving devices. The dependent variable would be the decrease in pressure ulcer rates, which is how you will know the change is working. Nursing in itself is about adapting to your setting. So adapting is what we should do. You do what you can with the supplies and information that you have. You know the change is working. You will notice that the pressure ulcer rate is down. If it goes up, then the change did not work and something else will need to be done. To see results, you will need to do skin assessments on all the patients, monitor them for 90 days. If the change does work, making a policy and procedure would be the next step. Then in-services and training will start about the new policies. The in-services regarding skin care should be part of the yearly eval to make sure it is of high priority.